Hi everybody, my name is Rachel Katie. I'm an OBGYN at Cuyuna Regional Medical Center. I also work at Riverwood Healthcare Center in Wellia and Mora. And I'm here to talk with you about menopause. Menopause Awareness Day is this month, October 18th. And we like to take this opportunity to just touch on some of the more common symptoms of menopause, highlight what the newest information is, and shed some light in what can be kind of a hard time of life to navigate. It's not as easy, unfortunately, to find what the real information is, what the newest trends are, and for women to ultimately be informed to make collaborative healthcare decisions. So without further ado, we're going to just get going here, talking about menopause A to Z, if you will. So this is just a screenshot that I took, but I thought it was kind of telling. Women spend about a third of their lives in postmenopause, and so often I see patients that'll say, well, you know, maybe they're 65, and they say, oh, I went through menopause, I'm done with all that, I don't have those hot flashes anymore, but I am having a lot of vaginal dryness, and I'm not as tall as I used to be, and I'm having problems sleeping at night. And actually, those are menopause symptoms. So you're either premenopausal or you're postmenopausal. And so kind of how you set the stage for the latter third to, in some cases, half of your life really does matter, especially in that 40s age range. And so we want to talk about that. Now, another screenshot just of the body, and what isn't commonly known is that there's estrogen receptors throughout a woman's body, including in her brain, heart, our blood vessels, kidneys, uterus, ovaries. And so basically every single organ of our body has estrogen receptors and responds to estrogen. So with menopause, you stop producing estrogen, whether it's because your ovaries have been removed or they've naturally run their course. And so when estrogen markedly decreases, it's no wonder that patients can have a whole plethora of symptoms. And it's important to know that it's not a one-size-fits-all. Some women don't really have much for hot flashes, but they have a lot of joint pains. And certainly there's other factors that you want to think about that can cause some of the more common symptoms, but these are sort of a list here of kind of the more common symptoms women will notice at that menopause transition. So again, I'm not expecting people to sort of belabor reading the slides here, but just that it's a reference for you so you can look back over these Facebook Live talks. But I'm just going to highlight the important points. So the average age of menopause in the United States is 52. Menopause is no bleeding for a year. And so again, sometimes if somebody's had a hysterectomy, we might need to do some blood tests or those kind of things. But that's what menopause is. And again, that's due to the ovaries no longer working or being removed. So the estrogen levels go down significantly. So really important point to know is menopause signs and symptoms. What's bothersome to women, what's confusing to women, is those symptoms for most women start well before menopause. So that's called the perimenopause. That's the time frame leading up to menopause. And for the average woman, that's for a number of years, 5 to 7 years, that she might start noticing irregular periods, more difficulty sleeping, mood swings, just really not feeling herself, vaginal dryness, all those kind of things. So I will oftentimes see patients in my clinic that will say, you know, I know it's not menopause because I'm still getting my period, but what's going on with me? And oftentimes it is perimenopause. That's when women are typically the most symptomatic. Their memory is not as good. They feel like they're kind of in a brain fog. They're exhausted. So to know that that is when menopause symptoms start for women is in those years leading up to it, perimenopause. So let's just talk about vasomotor symptoms, and that's just a fancy term for hot flashes. And it's the most common symptom in that menopause transition. Menopause transition is another term for perimenopause, so we're kind of switching over here. Most women experience it. We're not exactly sure why it's more prevalent in certain ethnicities than others, but that certainly is the case. and commonly called hot flashes, and oftentimes can be characterized by some cold symptoms after, like a chilled symptom. And for some women, it's very mild. It's just something that's just mildly bothersome. But for other women, it's incredibly debilitating. They don't even feel like themselves. It starts out in their chest area and works its way outwards. And it can be absolutely embarrassing, soaking with sweat. And it can really be hard to function with that. So on average, it lasts for about 7 to 10 years. That's a lot longer than we initially thought. And for about 10 to 20% of women, it's lifelong. I should say, what causes it is estrogen levels plummet, and there's a center in our brain called the temperature regulatory center in our hypothalamus that actually regulates our body's control, our body's adjustment to temperature. And so when estrogen levels plummet, essentially that center loses its control to regulate a woman's temperature. And so what's seemingly a meaningless temperature change in the environment, there'll be like this over-exaggeration for these people. And it can be quite bothersome. So as far as, well, what do you do about that? So there's non-prescription therapies, like cognitive behavioral therapy is actually very well studied, very effective. There's some evidence about soy and some of those other supplements because they have an estrogen type effect, but not really long-lasting benefits. And you have to eat an insane amount of soy to get any sort of possible benefit, so not a lot there. Certainly behavior modifications, those fans, those cooler temperatures, all those kind of things. The gold standard treatment for vasomotor symptoms is hormone therapy. That's one of the things it's indicated for. Not everybody is a candidate for hormone therapy, and I'm going to be talking a lot about hormone therapy, but I do not want to discount women who have contraindications, primarily two main groups. And that would be women who have breast cancer or breast cancer survivors, and women who have struggled with having some blood clot history, like blood clots to their lungs, legs. So those are two groups that, hormone therapy is not indicated in for the most part. So I'm going to try to also highlight non-hormonal treatments for these different symptoms that I'm bringing up. So hormone therapy, gold standard, works great. Certain antidepressants, such as paroxetine, are also approved for helping with hot flashes. A really cool one, it's at the bottom there, oxybutynin. We use that in a really low dose, lower than we would use for bladder. That's a bladder medicine. We use it twice a day, and that is an awesome option, especially for patients with or having had breast cancer. Great option for hot flash control. So just to say that there is a statement from the North American Menopause Society about using hormone therapy, and that this is the best treatment for hot flashes as well as vaginal dryness. It helps to prevent bone loss. And really the main hoopla with this about 20 years ago was they were using that Women's Health Initiative, and women who were a lot older, than the average woman were starting hormone therapy on. So yeah, there were more complications with breast cancer and blood clots. But in that study, those women were about 10 years older than the average woman that were actually using it in. So when we reanalyze the data, this is a very safe option for most women. Again, not an option for certain patient populations. So genitourinary syndrome of menopause is basically, I'm going to kind of highlight that here. GSM, essentially commonly known as vaginal dryness, but it's not just the vagina. Anything in between our legs is estrogen dependent. That's the outer area and the inner area. And so most women experience to some degree dryness. They'll have terrible pain with sex, itching, burning. They oftentimes will have recurrent UTIs, general discomfort. Again, this isn't everybody, but it's one of those things that estrogen affects the tissue, making the tissue stretchy and well lubricated. And so when you lose that estrogen, these symptoms follow. And so it's one of those things that actually gets worse with time instead of better with time. Now, not everybody has the same degree of symptoms, but most women experience something. So non-hormonal options, lubricants, it's important to know that lubricants are water-based. So that means that the effects go away in a couple minutes. And so, it makes things slippery, but it doesn't do anything to the actual integrity of the tissue. I think that moisturizers are probably a better option for most women. There's a list there. That last one is actually hyaluronic acid, which is something women will use on their faces for wrinkles or whatever. But using moisturizers at least several times a week on a maintenance basis really helps that tissue become stretchier and healthier and less painful, less irritating. The gold standard treatment is certainly vaginal estrogen. Vaginal estrogen is not hormone replacement therapy. Where you put it is where it stays. In some cases, vaginal estrogen is certainly an option for breast cancer survivors as long as they're no longer taking their tamoxifen or other aromatase inhibitors in conjunction with their oncologist. But it's a local effect, and the point is not to help with hot flashes, but to help with that skin, basically, in the vulvar and vaginal areas. So sexual concerns peak during midlife, and so about 40 to 50% of women at some point in time will experience some degree of sexual dysfunction. Those ages, mid-40s to mid-60s, is when it's most prevalent, and usually the concern is more of a desire issue. They recognize that they simply don't have the desire. They're not really sure why. It's kind of the last thing on their list, and when it's a problem is when they miss it. They're saying, you know what, I wish that was still a part of my life, and I don't really, and it's upsetting to me, and I don't really feel why that's happening. And so basically, you want to get a good history from patients and see what their living situation is, partner situation, what medicines they might be on that could be adversely affecting sexual desire. But so it's more than just starting patients on more medicines, but really looking at the full picture. Is there pain, that kind of thing. But there is, I think, 2 points with this. So HSDD stands for hypoactive sexual desire disorder. And there is finally actually a process of care of how you actually approach these patients. And so that's something that's actually new for women, and it's welcomed from the medical community. And it's different for how you approach premenopausal women. There's a couple different medications that are actually FDA approved for that. And for postmenopausal women, that testosterone is actually felt to be a very good option for women who have low desire, and they commonly will have low testosterone. And that typically will help desire to an extent. Certainly there's other components as well, but the important thing is that it's not just a black box anymore. I mean, there's certainly a process of care. So the blue highlights women with sexual dysfunction, and so in that early years, year 1, about 42% of women will have some degree of sexual dysfunction, but in the late menopause transition, at least at 8 years out, 88% of women will note some degree of sexual dysfunction. So this is far from anything to be embarrassed about. It's certainly more common than we all think, and it's important to address it, just like it is for men, which is like every 3rd or 4th commercial on TV. Weight gain is something, if I had a nickel for how many women, and certainly myself included, come in and say, you know what, all this weight's coming on, I'm eating the same, I'm doing the same exercise, and I'm gaining weight. I really cannot win. And this is extremely frustrating for women. And we do know with that menopause transition that the average woman gains about 5 pounds and commonly about 1 to 2 pounds a year. And unfortunately, the most common weight range for a menopausal woman is actually class 2 obesity. So it is no secret that our metabolism goes down. That's just no secret. So weight gain in midlife is incredibly common, and it's associated with all sorts of awful things. It's a risk factor for cancer, including breast cancer, diabetes, heart disease, all of those things. And so when our estrogen levels decline, we become a little bit more testosterone dominant. And when we do gain weight, it's in our waist. And so the big take-home point, if I can just say one huge thing, in addition to getting your aerobic exercise, weight-bearing exercise is paramount. And that's because if you build muscle mass, you're going to burn a lot more calories at rest. And so women are not going to bulk up. We talk about essentially eating whole foods. In the United States, about 20% of our foods comes from liquids, pop and that kind of stuff. So really watching that. Mediterranean diet and DASH diet are felt to be the best diets for menopausal women. And that's also because nothing's being completely eliminated. It really comes down to whole foods and moderation. So osteoporosis is the theme this year, actually, for International Menopause Society. And this is something that really is that hidden disease. Nobody actually sees osteoporosis, but this is what it looks like on the inside. Normal bone on the left and osteoporosis on the right. And so basically it's a breakdown of the bones, and it markedly increases your risk of fracture. Estrogen supports bone health, and so again, it goes back to our estrogen levels decline, and that certainly is a risk factor for osteoporosis, as are other risk factors too, but that's one of the things that occur. So in 2016, 1.6 million Medicare patients suffered from 2.1 million fractures. And it's important to note that 30% of hip fracture patients die within a year. And so when you think about that, it really does matter if you have healthy bones. Like, we're not seeing it necessarily. So what can you do for that? So again, aerobic exercise is really important. Balancing, strength training, vitamin D, about 1,000 international units a day, some degree of calcium, ideally about 1,200 milligrams a day. And weight-bearing exercises, increasing your muscle mass. Again, that's awesome because you increase your metabolism, and it also makes you less prone to falling. So what somebody can do on their own is you can get online and figure out what your risk factors are, and what your risk score is, and that's called a FRAX score, F-R-A-X, and it asks you a bunch of questions. And helps you to realize, am I at higher risk because I have rheumatoid arthritis, or I'm on steroids, or, I had this fracture in my foot for no good reason. I don't know why, or I fell from a standing position and now all of a sudden I have a fracture, or I'm losing height. Really think osteoporosis. And so most of the time we start getting DEXA scans at age 65, but what's new is that a lot of people really need to have DEXA scans before age 65. So be a little proactive with your health and check your FRAX score and see how you kind of fall in, if more of a low risk, high risk. And always, certainly, it goes without saying to talk with your doctor or care clinician. So other common metabolic disorders in midlife women is heart disease. We've talked about this in other talks. Heart disease is the #1 killer of women. This is a huge thing to sort of take in, and it goes against all the little headlines that were out for the last 20 years or so, but now we're through the weeds, and the take-home point is this: HT, which stands for hormone therapy, and heart disease. Hormone therapy started within 10 years of menopause, or under the age of 60. So earlier, younger menopausal women probably reduces coronary events, meaning less heart attacks. So that is not the same for women who start hormones later in life, mid to late 60s, not so much. You actually do not see that heart benefit. So younger women being on hormones is actually cardioprotective, and there's some information on that as well from the American Heart Association. So, that's kind of a big deal to consider that. And again, talking with your clinician, but this is not commonly known, it's not commonly understood. It is a timing issue with hormones. Younger women, it's a great idea for most people for their hearts. So again, the position statement on this is that when hormones are started at a younger age, it probably reduces heart disease. And we do know that also reduces our diabetes risk and overall mortality. So being on hormones helps to lower diabetes as well. So these are all important points to bring up for women, again, that you're making an informed consent. Obviously, it's crazy to only mention hormones when we talk about diabetes, but certainly you're going to be on all the hormones that you want. And if you're not making lifestyle changes, looking at that Mediterranean diet, being aware of your cholesterol and exercise, then we're missing the whole picture. So it really is the basics in a lot of cases. So cognitive changes, again, I kind of alluded to that menopausal women are not sleeping very well, very commonly. They feel like they're kind of in a brain fog, and they really get frustrated with losing sort of verbal memory recall, like forget a name or forget, words to a song or whatever, and it's really frustrating, or what was I going to say next? And, it's not completely well understood why that occurs, but and it's usually more in that perimenopausal age, those years leading up to menopause, but it certainly is frustrating. A lot of women are worried they're getting Alzheimer's, or maybe their mom had Alzheimer's or whatever. But the good news is that's a temporary thing. It does get better with time. Those kind of symptoms are not the same as Alzheimer's, where those patients don't realize that they're having a problem. And so, but it is really important. And a lot of things being out in the news right now as far as does being on hormones actually help decrease your risk of Alzheimer's? And that the verdict still is out on that, but it's thought that possibly for women who start hormones in those early years. And so that's kind of the difference. But anyway, common, that brain fog, and the good news is that you get through it, okay? And you're not getting Alzheimer's with it. But a lot of women too, with that comes some depression. And so it's important to realize that in addition to being on antidepressants, getting cognitive behavioral therapy, that hormone therapy can also be quite helpful with mood. And that's a new thing, and that's for perimenopausal women. So we have estrogen receptors in our brain, feeds our brain. It makes sense that now knew that estrogen is actually part of that sort of triad of care in addition to therapy and antidepressants. So take-home points is depression and anxiety are very common at this age, and you shouldn't ignore it. Again, oftentimes fueled by poor sleep or hot flashes, not for everybody, but there certainly is a window of opportunity to treat. So going back to that with the sleep disturbances, about half of women really struggle with problems with sleep. And so if you're waking up tired, if your partner tells you that you're snoring, you want to think about menopause stuff, but you also want to think about sleep apnea, restless leg syndrome, all those kind of things, because untreated insomnia is a risk factor for a lot of other health problems. And certainly sleep hygiene, kind of things to sort of check off your box. Looking at your phone in the middle of the night is stimulating to your brain. It's really not a good idea. The bedroom is for sleep and for sex. It's not for TV. Trying to avoid naps, little things like that sometimes can really go a long way. Hormones are not approved for sleep, but sometimes it can have that secondary benefit if women are able to not have as many hot flashes at night. I'm just kind of wrapping it up here. So really common that women will have some hair loss during menopause. There's a workup for that. You want to look at the whole picture. Not everything is related to estrogen, but estrogen does make our hair grow. It kind of supports our hair. But you also want to think about, is somebody anemic? What's their testosterone level, their zinc level? Sometimes there's some underlying eczema, and they might need to see a dermatologist for a little skin biopsy. It really depends. The only thing that's FDA approved for female pattern hair loss, sort of that thinning of the hair, is that topical minoxidil, Rogaine. And so using that on a maintenance basis can kind of help to stabilize the hair, certainly minimizing a lot of products or blow drying the hair. Some off-label use of spironolactone or finasteride or Propecia. So lastly, we have our little friend here that women have to deal with periods, pregnancy, childbirth, breastfeeding, menopause, hot flashes, etc. But men have to deal with women. So I guess we're all in this together. And if I can say, take home point that these are common symptoms, are not to be ignored. Everybody experiences menopause differently, but you're either premenopausal or postmenopausal. And we're here to help you kind of work through the weeds and make collaborative decision making and addressing you as a whole person. So thank you so much for your time, and I look forward to your questions.